With a midline incision, no major vessel, nerve or muscle is severed. This is important for the degree of functional impairment of the abdominal wall after surgery. The risk of a wound adhesions or an incisional hernia is similar with a midline incision and major transverse incisions. Considerable knowledge is available concerning surgical technique when closing midline incisions in order to minimize the rate of wound complications. The suture must be able to hold wound edges into apposition during the first 4 weeks after the operation. If the epinephrotic edges become separated more than 10 mm, an incisional hernia always develops. A monofilament suture material should always be used, since the rate of wound infection is lower than with braided materials. After 3 to 4 weeks, the sutured epinephrosis has gained about 50% of its original strength. The suture material should therefore be a non-absorbable or a slowly absorbable that contributes to wound strength for at least 6 weeks. With a fast absorbable material, the risk of developing an incisional hernia is higher. A running suture technique should close a midline incision. The rate of wound complications is similar as with an interrupted technique, but a running technique is faster. Vascularization and collagen deposition is also improved with a running technique. With a running technique, self-locking knots should be used for the anchor knots. Compared with conventional knots, self-locking knots are smaller, have a minimal effect on suture strength, and cannot slide. A midline incision should be closed in one layer. Closure in multiple layers is time-consuming and has been associated with a high rate of wound adhesions. The stitch should include the epinephrosis only. Both experimental and clinical studies show that large tissue bites that include muscle and subcutaneous fat increase the risk of wound infection and incisional hernia developing. Then the mechanism is that the suture compresses or cuts through subcuticular fat and muscle, as illustrated in figure B. This allows the epinephrotic edges to become separated, with the subsequent development of an incisional hernia. With tissues compressed and devitalized, the risk of wound infection is increased. The length of suture used for closing the wound must be 4 times longer than the wound. With less material used, the suture line will not be able to hold wound edges into apposition. The risk of developing an incisional hernia is 3 times higher in wounds closed with a suture length to wound length ratio of less than 4 than with a higher ratio. The length of suture used for closing the wound can be calculated by measuring suture remnants. The length of suture remnants at the beginning and at the end of the suture line is subtracted from the initial suture length. Wound length corresponds to the length of the skin incision. A suture length to wound length ratio of more than 4 should be accomplished by placing many short stitches at close intervals. 4 days after closure, the wound is weaker with large tissue bites at greater intervals.